Good morning, everyone. My name is Maiwan Banai, and today I will present my service improvement project titled Inclusion of a Clinical Psychologist into Post ICU Rehabilitation to Improve Patient Outcomes. I developed this service improvement project during my recent employment in intensive care unit. Working in respiratory physiotherapy section. The aim of this project is to improve rehabilitation pathway for patients who survive critical illnesses by incorporating psychological support into post-ICU follow-up review. I will first present the clinical problem and then give you the rationale for the service improvement. And then I will use one of the quality improvement methods to implement this program and discuss the expected outcomes, financial implications, and sustainability. Improvement in ICU care have definitely improved the survival rate. However, many ICU survivors experience long-term complication post-ICU care. Collectively, these impairments are known as post-intensive care syndromes. Physically, the patient lose muscle strength, which is known as ICU acquired muscle weakness. That in turn impact patient swallowing and their mobility. Scheffel et al. 2020 in their review suggests that a patient on average loses 4% of muscle strength with each day of staying in ICU care. Neurocognitive impairment include visuospatial scale. Visual means got to do with vision. Spatial means with patient being unable to locate themselves in space and time. That in turn negatively impact patients' executive functions, their attention, and summary. So as well as these physical and neurocognitive problems, psychological problems are very common. Research has shown that about 45% of ICU survivors suffer from depressive disorders, and about 35% from anxiety disorders, and 25% of patients suffers from PTSD or post-traumatic stress syndrome disorders. So despite all these psychological impairments, no psychological support is offered in post-ICU review. The current ICU follow-up include 2 physiotherapists, 2 critical care outreach practitioners, and 1 consultant. However, no psychological support is offered. That means many psychological impairment remains undetected. So the aim of this service improvement project is, the first aim is to improve patient outcomes by addressing both the physical and psychological aspects of rehabilitations. The second aim is to improve cost effectiveness by reducing the readmission rate and also improving patient outcome into rehabilitations. The third aim is to promote multidisciplinary team collaboration and bring about a change in cultures by addressing the issue of psychological support. Research is very conclusive that psychological barrier impedes rehabilitation or adversely impact the rehabilitations, because many ICU survivors exhibit fear avoidance, low motivation, anxiety, and PTSD. That in turn reduce their physiotherapy engagements. As well as the psychological symptoms following ICU admissions are associated with impaired activity of daily living and ambulations. So therefore, holistic approach is needed in order to rehabilitate an ICU survivor. For this reason, this service improvement project is underpinned by biopsychosocial model of health. Biopsychosocial model of health suggests that our health is the byproduct of our biology, psychology, or social world, or is it the interaction of our biology, psychology, and social world? They are all interdependent. I already spoke about the psychological and biological aspects of these impairment. In regard to social world, so as much as ICU admission is a trauma for the patient, it is also a family trauma. Research has shown that over half of family members of ICU patients experience anxiety or depression symptoms. As well as this, that National Institute of Care Excellence 2019 suggests that both the physical and non-physical aspects of health needs to be considered when rehabilitating an ICU survivor. Healthcare professional council as well emphasize holistic person-centered care, and also Chartered Society of Physiotherapists guideline 2024 emphasize biopsychosocial approach toward physiotherapy. To find out that why psychological support is not offered in post-ICU review, the root cause analysis was carried out. In this root cause analysis, the fishbone diagram revealed that there were several factors impacting the absence of integrated psychological input into post-ICMDT follow-up. In regards to workforce, it was limited staff training, system service design, again no structured psychological screening pathway, resources, lack of funding, and limited MDT capacity. Culture-wise, again, medical healthcare is still predominantly biomedical, and usually psychological recoveries are undervalued in rehabilitations. To dig a little bit deeper and find the root cause, the 5 why analysis was also carried out. The 5 why analysis asked repeatedly the why question 5 times just to find the root cause. So as you can see, the second why answer was that physical outcomes are prioritized, which consists of mobility and respiratory. Why that's the reason? Because again, biomedical model dominate the ICU care. And why that's there like that? Because there is limited awareness and advocacy for PICS or psychological impact. Smith et al. In their review says that the terms post-intensive care syndrome was only coined 10 years ago, so there is still limited research and awareness about this. That in turn leads to lack of advocacy. Lack of advocacy leads to limited funding from NHS. So to translate my aims into action and implement this service improvement project, I'll be using a PDSA framework, which is a quality improvement method, which is usually used in NHS. This quality improvement method tests the intervention on a smaller scales to test the ground and then see if the coasts are clear. If successful, then it can be implemented into larger kind of scale. The PDSA cycle stand for plan. In a plan phase, you're just kind of planning the interventions. And the do phase, that's where you are carrying out a pilot program. And then in study phase, you're comparing your results. If successful, and then you act upon that, you can embed the intervention permanently in the trust. So considering PDSA cycle, the plan stage would include identifying service gap, which we already did, and selecting project lead. Again, we will be selecting a person, who will be leading the project, an established timeline at this stage, engage stakeholders. Stakeholders are the people who will be mostly impacted by this service improvement project, like patients would be the most impacted, and also the stakeholder include the people who have the highest power that could allow this service improvement project to initiate. For example, NHS, National Health Services, who are providing funds, they will be the highest, they will have the highest power to allow the initiation of this project. At this stage, I will be also defining my inclusion criteria, so that would include ICU stay more than 4 days, and then I'll be collecting 6 months baseline data, so that it could be compared when the intervention is completed. And I will also be kind of establishing measurable outcome measures. So in regard to establishing timeline, the first month will include MDT approval, the second month staff engagement. By the end of second month, I will have a psychologist in clinic, and then we will obtain our measurements. And then after 3 months, we will obtain our measurements again to compare it with the start of the 3 months, and then we will analyze our data in the final month, 6 months. We will kind of evaluate and consider sustainability in decision making. Do is the second phase. That's where the 3-month pilot intervention will start. At this stage, I will be also collecting physical outcomes and psychological outcome. The physical outcome would consist of 6-minute walk test, and again medical research council SAM score. This outcome measure tests muscle strength, and it's being scored on the scale of 0 to 100. And then the next test is Barthel Index test, that measures activity of daily living on 10 domains. For example, bathing, washing, dressing. Again, it is scored on the scale of 0 to 100. And then there is the Fall Efficacy Scale International tests outcome measure. This is a self-reported questionnaire which assess the confidence of the patient in regards to falls and moving around the house. For example, 0 is the least confident and 10 being is the most confident. In regard to psychological outcome, I'll be using hospital anxiety and depression scale questionnaire. Again, this is a self-reported questionnaire. It has 7 questions on domain of depression and 7 on anxiety. I will also be kind of collecting patient satisfaction questionnaire. I'll be using to see, how patients are satisfied. And other event to measure an improvement in post-traumatic stress syndrome, I'll be using impact of event scale revised test. Again, this measure PTSD on 3 domain. The first is fear avoidance, the second is intrusions, and the third domain is hyperarousal. At this stage, an MDT outreach program, I will be also considering, proper referrals. It will be a conjoint appointment with the psychologist to identify proper avenue where patient could be kind of referred to, be it physiotherapy, psychological services, GP, pulmonary rehabilitation, in support of continuity of care. Research has shown that up to 40% of ICU survivors do not return to work within the first year. So it is really important, to refer patients to proper avenue where they can help them with some employment as much as the patients are capable. This is also in line with the National Health Services long-term plan that is striving for reducing reliance on hospital and then shifting the level of care more to community. I will also be measuring cultural and MDT change by using Team Climate Inventory Questionnaire. Again, this is a self-reported questionnaires which measures the level of MDT collaborations, communication, and staff confidence. Research has shown when the staffs are heard and they are valued, they can perform better and in turns improve the service and care for people. Okay, the study phase, this phase is at the end of 3 months. Now I will be comparing my data pre and post outcome measures. For example, in a 6-minute walk test, improvement of 30 minutes would suggest a significant improvements. In a medical research council SAM score, increase of 48 point would signify success. In regard to Barthel index improvement, 10 to 15 point improvement will suggest success. And also the fall efficacy score 4-point increase would just suggest that patients have improved a lot. They have gained more confidence. And in regard to psychological outcome, 6-point reduction in hospital anxiety and depression symptom would signify success. And in regard to impact of event scale revised score, a reduction of 9 would suggest success. In regards to service outcome, I will be comparing readmission rates. A decrease in readmission rates would signify success. And also I'll be assessing patient feedback and staff feedback at this stage. It is also prudent at this stage to kind of consider the financial implications. According to Department of Health and Social Care, an ICU admission costs NHS about 10,000. And a clinical band 7 psychologist can earn up to 50,000 salary yearly. Suppose if the trust hire a part-time psychologist, his salary would come up to 12,500 when he's working 7.5 hours per month. And now, if we consider that psychologist input who could prevent 2 ICU admissions or prevent 5 hospital admissions, the net estimated saving will be 11,500 for NHS. Again, these are just hypothetical scenarios. However, not only financial. So, as I said, not only will be considering the financial benefit, we have to also consider the non-material, non-financial benefits. In regards to patients' benefit, that leads to this project: improve psychological well-being, better rehabilitation engagement, improve quality of life. Staff-wise, it could lead to increased confidence, better MDT collaborations, and reduce moral distress as well. It is also in alignment with NHS long-term plans. So one of the hallmark of NHS long-term plan is that from sickness to prevention, because this service improvement project leads to preventative measure as well as that it also kind of leads to a reputational improvement for the trust. So it's also important at this stage to kind of consider the driving forces and restraining forces. I will be using 11 force field analysis for that. I think, this service improvement is very viable and feasible financially. The driving forces include improved patient outcomes, cost effectiveness, and it's also in alignment with NHS with the NICE guideline and NHS guidelines. But the restraining forces would include funding pressures, workforce capacity, again cultural resistance, as well as I mentioned earlier that the medical care is still very biomedical focused. There could be some resistance in regard to that. It is also important to have some contingency plans or backup plans in case some barrier arises. For example, if there are barriers, I could improve MDT engagements, provide additional staff training, refine referral criteria, extend pilot duration, and adjust psychologist time and salary. So again, if I don't achieve the outcome, I could reevaluate the intervention design and repeat the PDSA cycle. So, and then if the pilot was successful, then I could develop a formal business case, secure recurrent funding, and embed psychologists permanently within the MDT. At this stage, I could also explore scalability across the NHS, within the trust, and disseminate information in social media and in conferences so that service improvement project could be embedded nationwide. So it will have all the benefits that other trusts can gain from our experience. So to conclude, I've discussed that ICU survivor experience both physical and psychological impairments, and research has shown that psychological impairments reduce engagement in physiotherapy. Therefore, by addition of a clinical psychologist in post-ICU rehabilitation, we may be able to improve rehabilitation participation, improve functional recovery, reduce NHS costs, and also it's in alignment with national policy. It could also support a more holistic rehabilitation pathway for ICU survivor. So here are the references. Here is last page. Thank you so much for listening, and I hope you enjoyed that. Thank you.